The newer drugs, we have to be very careful. Short of a few years of good experience, and even then, the drugs continually surprise us with effects that were known in the very first tests of the drug, but that, somehow we, dampened because there was excitement about some other effect. But then they come back and then the drug goes off the market, or then we realize, oh my God, that was a bit of a disaster. Or now we need the newer drug again to replace that.
Somebody get this guy some help!
Or, put more simply,
if you need help like this guy, call your own doctor.
So I wanted to preface part 3 of my series with David Cohen by mentioning a few things about lithium before he and I go on to discuss it further. And so I'll just say that I think you could create a data set that shows whatever you want it to show fairly easily. We see the pharmaceutical industry doing this regularly by cherry-picking data with a predetermined destination or outcome in mind. I also think other researchers can oftentimes be unaware of their inherent biases, and it's important to regularly consider whether or not one's opinions or conclusions are wrong. Hence why the scientific method is predicated on trying to disprove what's called the null hypothesis, aka the thing that you think is having an impact. You are actively trying to prove that it has no impact, going against your theory. In terms of evaluating evidence, you cannot rely on one meta-analysis or one set of data. You have to read and study as much of the data as possible, being aware of the financial backing and possible motivations of the researchers, and draw the best and most reasonable conclusions while embracing uncertainty that you can. So, meta-analyses can be fraudulent. They can include bad data. I personally think an extremely well-designed singular study can often be more valuable than a meta-analysis where the evaluators were not in any way involved in the original studies. So, in regards to lithium, while we don't know everything about how lithium works, or I would say really, we don't know everything about how most drugs work for that matter, we know quite a bit. And we have some very reasonable conclusions as to how it works on different systems. For one, and maybe most relevant in terms of recent findings, in its preventive effect against Alzheimer's, I would encourage you to look at Harvard Alzheimer's lithium research as of the beginning of August 2025, is this impact on glycogen synthase kinase 3 beta, or GSK 3 beta. The inhibition of that enzyme produces a downstream robust anti-inflammatory effect. Lithium also has this ability to replace sodium in the nucleus of manic or depressed phase neurons that have been shown to have elevated levels of intracellular sodium. And this is on a concentration gradient. So this theoretically at the right dose does not affect normal neurons or those without elevated levels of intracellular sodium. Lithium works by directly inhibiting viral replication of DNA viruses in this wide family of herpes viruses. This may help provide explanation as even the class of herpes viruses has been implicated as a causative factor in dementia and mental health conditions. Lithium has the ability to cause what's called demargination of neutrophils or immune-fighting cells that increase the initial immune response to pathogens. Lithium has a proven benefit in increasing helper T cell counts or other immune cells in HIV patients whose immune systems, if it progresses to AIDS, have a difficult time fighting potentially fatal opportunistic infections. We see improved outcomes in COVID-19 and COVID-19 immune sequela. We see that in animal and human studies, lithium promotes BDNF production, generates BCL2 proteins, which inhibit neurons from programmed cell death when damaged. and also instigates hippocampal neurogenesis, the area of the brain implicated for long-term memory. This lends more evidence to a neuroprotective and anti-dementia and or a memory improving potential. It's also used in post-stroke recovery, in chronic migraine and headache disorders. There's possible mechanisms that may reveal that it'll improve outcomes in Huntington's disease and multiple sclerosis. There's even studies of its use in ALS, or Lou Gehrig's disease, a progressive and rapidly progressive fatal condition involving motor neurons, where lithium prolonged survival by 35% in a 44-patient human clinical trial. After 15 months of lithium treatment, that group had no deaths, and the standard of care, riluzole, treatment group had 30% of their group dead. More recent research implicates genes that can predict lithium responsiveness. We have other information in terms of bipolarity that shows that lithium can regulate the expression of circadian rhythm genes, our internal clock that tells us when to sleep and when to wake up. There's also an absolute litany of evidence over the last 100 years revealing so many benefits in what we now categorize as bipolar disorder, as well as good evidence in prevention of unipolar depressive episodes. Not to mention, lithium passes the ancient wisdom test, as several ancient cultures, including the Greeks and the Cherokee Indians in northwest Georgia, bathing in highly lithiated waters as a general health tonic and mood-boosting bath. Additionally, in terms of risk, there's a lot of evidence that lithium's side effect profile is extremely dose dependent, and that most of the major or severe side effects are related to brushing up against toxic doses of lithium, just as you could have a toxic dose of sodium or potassium or calcium, etc. There are even nephrology or kidney doctor researchers looking at potential positive effects and long-term benefits on the kidneys when lithium is used in low doses that do not approach toxicity, with other researchers looking at its widespread anti-neoplastic or anti-cancer benefits. There was just a recent February 2025 JAMA Psychiatry review revealing that higher lithium content in the groundwater is associated with lower rates of all cancers throughout the United States, and lower lithium content in the groundwater is associated with higher rates of all cancers. I happen to live in an area of low lithium content in the groundwater, which may explain some of the robust responses that I have even with extremely low doses of lithium. There's data accumulating that low doses lend to a decreased risk of osteoporosis, which is possibly a contributing factor to why bipolar patients on lithium live longer than bipolar patients on other mood stabilizers. And there are even potential cardioprotective musculoskeletal benefits. From John Cade's 1949 incredible 10-patient case series on institutionalized manic depressive patients, including his first patient who had been in a constant state of mania for 5 years, being able to be discharged after a couple of months on lithium, to Mogan Scow's necessary use to help control his brother's bipolar symptoms, to Alec Coppin's long-term work showing how much better survival was and how much lower the suicide rates were in his lithium-treated patients compared to non-lithium-treated patients for over 20 years in unipolar depression. There is so much evidence for lithium's effectiveness, and it's so important to mention. Nearly none of its research is pharmaceutically funded. These are researchers who have belief based on the evidence they've reviewed, with folks like Walter Brown, Nasir Ghami, Rif El-Malik, Yanis Rybakowski, Sadir Gad, among so many other reputable clinicians and scientists. Michael Nels is another one, because they've seen and reported so much benefit in their patients, and it's reflected in the widespread data. For me, someone who's very skeptical of drug safety and effectiveness at baseline, especially in psychiatric research, I've seen a huge benefit with my patients as well. In contrast, there is quite a bit of incentive for other sponsored research to come to negative conclusions regarding lithium, as it's also the most preferred agent amongst patients diagnosed with bipolar and leads to reliance on fewer other psychiatric medications. As Rif Al-Malik said, if you want to tailor in a new drug, you've got to demonize and berate the old drug. Well, lithium is one of the oldest drugs, not to mention it's cheap as hell, costing my patients without insurance about $40 for an entire year's supply. So yes, there are people like Peter Breggin who tout that how toxic lithium is, but don't provide the nuance around its dosing. And similar to sodium, potassium, water, and so many other natural substances, a lack of it can lead to dire or at the minimum negative consequences, as studies where they intentionally lithium deplete animals yield dead animals. And also an excess of lithium can be toxic, to David's point, even potentially fatal. But I think it's dangerous to make uniform statements like lithium is a bad drug publicly without providing the necessary nuance regarding dosing and benefit risk analysis. I fear that sometimes with too skeptical or too contrarian of an attitude, which I definitively share and consciously have to rein in at times, it's easy to arrive at the conclusion that we don't know anything about mental illness and nothing works. If anybody desires, email me and I will send you a file on some of the data that I've amassed on lithium, because I think that you have to take into account the entirety of the research base and your own anecdotal experiences with it in order to draw reasonable conclusions and constantly reassess and recalibrate that benefit to risk profile. Anyways, hope you enjoy the rest of my conversation with David Cohen and appreciate the nuance as well as the back and forth discussion argument of our talk. Thanks for listening. Thanks for watching. Like, subscribe, all that stuff I hate to tell you to do, but I have to if I want the message to get out. So enjoy. And too far right for the left wingers. And in these debates, I find that I am not biologic enough for the biologic psychiatrists, and I rely too much on medication for those who are the furthest end of the anti-psychiatry movement.
I understand. I see. But let me tell you something that might help to rehabilitate you with your colleagues. It's that, there is one very strong biological intervention, if you will, that does produce result, at least in conditions like depression, and that's exercise. In a couple of meta-analyses, hope to send you one, I think, it's really very, very good. It's better than the drugs, good serious studies. So that stands out in a way that's the first thing we should recommend to people. Increase your movement. Do it in a somewhat disciplined manner. Walk every day. Increase your walking by 5 minutes a day. Stuff like that. I think that is really important. Now, I would like to see more doctors do that, and maybe more do. Maybe I just don't know. But that's biological because we have bodies. We're supposed to stand upright. We have strong legs to make us move. It's important that we do that. It helps with breathing. It helps with smiling, just to be standing up. And all kinds of things might change with a little regular exercise. And in controlled trials, it's been shown to be really good, at least equivalent, without the adverse effects. Add a dog to the mix. Add a dog, walking a dog to the mix, you'll see your communication improve dramatically in addition to your mood. So add a friend to the mix, then, your life begins to change. So I'm just saying that there are biological things we need to do because that's what we are. We are not much more than bodies, but our life, our thinking is social. Without understanding where our community comes from, what is acceptable and not as rules, what are the common things we share, don't share, reject, accept? Without that, then no utterance has any meaning. Brains don't walk around like in nature by themselves. They walk around in bodies that have evolved through years of a life. So you got to take the whole person in their context to make any sense of anything that the brain does. Otherwise, it's meaningless to just think the brain's disordered.
Here's a situation or example for you. You have a person who has a strong family history of people who have been diagnosed as bipolar or manic depressive, and they may even have a family member who has died by suicide with multiple suicide attempts within the family. And that person comes to see me, and I tell them, hey, we do have one medicine that has good evidence, even at lower doses, of reducing your actual risk of suicide. And there are so many different studies, so many types of different studies that reveal this effect. And in the experience that I do have, and the experience of much more well-versed psychiatrists that I've worked with, I think that you should start this medicine that will reduce your risk of suicide.
Okay,
Important
so
to minimize
yeah,
a risk
yeah.
that it doesn't matter if they get all of the social and community aspects lined up if they're dead.
So it's good that you pick suicide, very important thing. So number one, again, the latest findings is that a bit more people are thinking of suicide, and especially youth. So having suicidal thoughts, which I think is just par for the course. It's part of, to be alive. At some point, you have to think that you could end it, and you might want to end it. And how would you do it if you wanted to do that? So is that suicidal thinking? I'm not sure, but I think it could count as suicidal thinking. So we're all guilty of it, all of us, number one. It's not 13, 14%, it's 100% in my view.
From
But
what
my
I've seen,
point
it's
is, yes,
70, 75% of people will think about suicide
yeah,
at
yeah.
some point in their lives. Yes, it is a
Yes.
very normal thing that is
Very normal thing.
Right.
So we have the people that we ask the question that don't want to respond, that don't know, and then the ones that say yes. But in any case, right now, I think it's about 13 or 14% of people are classified as agreeing that, yes, I have suicidal thinking. And then of those, about 5% of all the people, not of those, but of the 12% of the people suicidal, about 5% suicidal plans, a plan. And then again, unclear how exactly that is defined, but let's say they've thought, I want to do it and I'll do it this way. And then it down to about 1.6 or something, or 2% that have tried, which is a lot. But now the actual suicide rate is much less than that. It's about, right now, let's say around, for overall, it's 25 to 30 per 100,000 people. So we're not in the percents. We're not
about
even
50,000 a year in the US.
Yeah, 50,000 a year in the US, exactly. And of which half are, yeah. Okay, so the fact is, so it's a very rare event no matter what. When a person tells you that, and they tell you in my family someone died, the fact is people try, 5% or so, or 2% make an attempt. That's 2 in 100. That's a lot of people. You're going to meet people like that. The point is you're thinking about it, say biologically, and that's fine. And maybe there are predispositions to that, but certainly having a family history, not because of genetics. If you have a family history of wealth or of a certain accent or whatever, it's going to be in the family because it's just what you learned. It's the custom of the family. It's a custom, and I say in the sense of it's in the family. It's a reference. It's discussed. It's not discussed, but everybody knows it. It's in there. And I'm acutely sensitive to these intergenerational things, these deeper social causes, social contributions to a particular phenomenon. So it kind of evolves over time and then it flowers at a certain time. And so that could be suicide too. I'm saying it's just as plausible to think this way as to think there like, oh, family history? Okay, you're at risk for suicide. And yes, people who have had relatives commit suicide are apparently much more likely to commit suicide themselves. And that, call it biological explanation. I call it just, it's an example. It's an example. It's part of the repertoire of what is done in this family. And that's very powerful, especially some charged event like this. So that's my view of suicide, of the way you framed it. But lithium now, look, there was that famous meta-analysis 2 years ago. Joanna Moncrief and her colleagues, a meta-analysis of all lithium studies, including the ones that did not count, that had 0 deaths, which were not included in previous studies. So if you want, I'll send you that one. I have it somewhere. It came out 2 years ago. And I believe Nasir Gaemi criticized that study recently. But the fact is, the evidence is not settled at all on lithium's protective effects on suicide, including
David,
by some pretty well-known deans and of thinking on the subject, like Baldessarini, McLean, and his colleague Lentondo. They say it's really not settled. There are no differences really in the studies between, lithium and non-lithium, or lithium and nothing.
You could make that argument for almost any scientific question, that there is data on both sides.
Yes.
I think that the data with lithium is much stronger. And the other factor here is the motivation behind who is conducting those studies and doing that research, because there is not a lot of motivation outside of personal bias for people to say that lithium is anti-suicidal. There's not much financial motivation.
But I just want to say that your justification for bringing that up is that in your practice, you say certain things and you bring it up, and that's okay, because you're that learned intermediary trying to make sense of the evidence in your view and giving it to the patient in what you think is in their interest. They have to make the decision, of course, but that's okay what you're doing. You're recommending to them something on the basis of your best judgment. And let's say that knowledge constantly evolves. So maybe your best judgment might not be best. My best judgment might not be the best tomorrow. We will take that for granted for both of us. But you make that recommendation, and I think that's fine. But it's up to the person to accept. But my view, having studied the prescription of lithium for a long time, very low doses, please. Otherwise, you clog up the kidneys. You screw up the thyroid system, you do, and you block thinking. And all you do is you slow them down. That's what you do. So it clouds thinking too. So that's okay, because they might find that useful. In your view, you might try to think that way. These are the effects of lithium. I mean, that's what it does. And so it might be good for them as a tonic. Tonics can kill you. Like a pound of garlic might do something bad, but a clove of garlic might be very good for you every day. So a little lithium.
David, I mean, trust me, like I really do agree with you on so many aspects of what you're saying. But I think that in regards to this aspect of the discussion, it can be really harmful for somebody to hear that, because, well, a couple of things. Again, I've got to reiterate. What you're saying about cognitive dulling is true on high and repetitive doses of lithium.
Yes, that's why I'm saying very low doses.
Exactly. Yes, very low doses. It may have a neuroprotective benefit at very low doses. And I think that's very important to understand the nuance. But here's my point. Here's my bigger point of how I believe that what you're saying could be harmful. And again, I've got to reiterate, I agree with so much of what you're saying. 50% of people who die by suicide do so on their first attempt. This is not something that we have a second chance for in about half of the suicides. So in that realm, not recommending in my position, somebody use, again, and I agree, I try to use primarily low doses unless I am treating somebody who is floridly manic and in a state where they could be a danger to themselves or others. You could go on the extreme on the side of what you're saying, and there could be harm there. And I certainly think that the more overall harm is done on the over medication and practicing what I call cookie cutter or drive-through psychiatry.
Okay, we can agree to disagree this way. Yes, I think that you've well characterized maybe what I've said, or I think you got it. At some point, we step back and we look at the whole system and we see just an increase in people getting medicated. We don't often see people getting much better over time. The outcomes, certainly in the eyes of numerous authorities, I don't know, the latest was Tom Insel, of the former director of the NIMH, who put out that book, I don't know, Steps to Healing or so. Essentially, he's saying it's a failed enterprise. He still doubles down on, Yeah, we do need more, biological brain research. It's not chemistry, it's electricity, whatever he says now. And
I
we always
100% agree with that statement. I think it is electricity. Yeah.
Well, there you go. You see, it was a chemical imbalance. Now it's a circuit imbalance. It's fine. It's all linguistic. It's all linguistic. Show me the money. Show me the money and replicate it. Get the Nobel Prize. Let's see where the real science is, as we say. But just to call it something else, before that, it was your mother did it to you. It was your unconscious impulses. Before that, you weren't a good enough Boy Scout. Whatever. We just change the language, but we don't improve the understanding. And we don't improve our capacity to deal with what appears to be increasing towards 100% incidence of mental illness. That's what, the dream almost of, you could say, are we dreaming to just get more and more people called mentally ill? Is that what it's about? Because that's what's happening. In addition, the people that we call seriously mentally ill, they're the least helped. So wait a minute, what's going on here? In other words, they're the ones that we say, well, they're on the street. But remember that every single revolution in thinking about what we do next is based on that small percentage of people we call schizophrenic. It's not working for them. The revolution didn't work. The drugs didn't work. In fact, they may have made things worse than before. We have more suicides than we did pre-drug. So all these indicators, we have shorter, fewer remissions, dwindling recovery over the time that we've had the antipsychotics. I mean, that's what Incel, the chief funder of all research, a neuroscientist himself, et cetera, says in those words. He says it in those words.
What's the definition of insanity?
Well, yeah, I don't know. There are many definitions.
Doing the same thing over and over again and expecting different results, right?
Yes. I knew you.
Yes. So David, I mean, we are fully in line. I would say that I think probably of all the psychiatric drugs out there, I would say probably 4 out of 5 are pretty much useless. I mean, yes, you could find some sort of indication.
4 out of 5. Okay, sorry, I heard 4 or 5. I thought, what?
4 out of 5 are useless. And then the other 1 out of 5 need to be tailored to the specific person, to the specific population. And we can't do that with 100% accuracy. So yes, I think describing that to the patient, that these are the potential benefit, the potential risk, what I think may happen. And yes, it is up to you to be able to make that final decision. I may be way off in terms of my first thought of what may help you.
It's not so much that you may be way off. You may be on. That way off, I take it as a constant. So we don't even have to bring it up. It's that you may be right on. But ultimately, I mean, this is the ethical issue, is that ultimately the patient still has to consent. In other words, ideally, in the ideal situation, it's the patient's decision. Your decision is what you're going to prescribe or offer or recommend. That's your decision, and how you're going to present it to them, and what arguments you'll tell them about what the risks are if they don't, what the risks are if they do, what the benefits are if they do, and et cetera. That's your job. But their job is to decide, actually. Whether it happens like this or not is not important. I think what we have in common too, first of all, I respect your trajectory, the way you comport yourself with your patients and the way you're thinking about this. I think it's just so refreshing. My point is that, again, population look, it's one thing to look at one person and to see what could help them in this hour of need, and to look at what has been happening over time. And then what are the recurring cyclical patterns? And so I kind of been focusing on the latter a lot, but I'm willing to understand that with one person that you're encountering, that you have a particular relationship with, either you know well or don't know well, and all this plays into it, you will make certain recommendations that you might not make if you are the czar that has to regulate, interventions or research or funding for what kind of services. And the large scale data to me says we have failed. We don't have a mechanistic understanding of what you call, mental disorders. There's still troubles in living, like Thomas Sauce called them. That's as good a definition as I can tell. They are some serious troubles in living and some less serious, but that's what they are, troubles in living, problems of living with other people. No one has problems with trees. No one has problems with telephone poles. They have problems with other people. Like the fellow who said, "You are piercing my heart." shot my heart to his mother. It's with his mother. He had a particular problem also. This is the stuff of it all. So I pay more attention to that. The biological stuff, it's kind of boring by now. It's boring to me. I mean, what, we're supposed to stay ahead of this? This is ridiculous. Now it's into the, the percentage of added risk from these 12,000 extra genes, and the percentage is getting smaller and smaller the more genes we say are implicated. So I'm not sure, what are you saying? What does that do to your practice with your patient? I say zilch. It just makes you think differently or make you more confident about what you're bringing to the patient. But what comes with your personal experience, I think, is what's valuable. You're telling me you've observed, you see your patients, you see patterns, you believe this, you communicate that to your patients. I think it's terrific. I think consent has to be part of it, remain very important. And drugs, they're here to stay. Yeah, just a few drugs. Learn a few drugs, be good about them.
One of the best teachings that I got was you have 10, maybe 15 drugs that you know inside and out, and those are the ones that you go to. You don't get swept up in the new state-of-the-art medication that is working on a new system. To me, that just screams dangerous because we don't know the long-term effects of that. My mother was a pharmacist, and that was probably one of the most valuable lessons I ever got way before I even thought about going to medical school. Was you do not take any drug that doesn't have 15 to 20 years of data behind it, because you don't know what the long-term effects, and that is what we're all going for. We want long-term stability. We want long-term meaning and fulfillment out of life.
That's my language too. That's my language. Yeah. The newer drugs, very careful. We have to be very careful, short of a few years of good experience. And even then, the drugs continually surprise us with effects that were known in the very first tests of the drug, but that, somehow we, dampened because there was excitement about some other effect. But then they come back and then the drug goes off the market, or then we realize, oh my God, that was a bit of a disaster. Or now we need the newer drug again to replace that. So there's some, proven drugs. There's tranquilization. There's stimulation. That's important. There's changing your perception, which is the hallucinogens we haven't discussed that are coming in, They're not too much. You can bring people down, bring them up, change their perception directly. And there's not much more that you could do with drugs. The rest of it, it's for them to learn, and in their own circumstances, how they could use it, how they could use what you consider an adverse effect, how they could find terrible what you consider a desirable effect. All that is them to discover and them to find out and them to experiment. It's not so much medicine there.
To your point about the anecdotal experience, which David Healy and I talked about as extremely important. Ken Gilman and I talked about as extremely important in how you formulate your ideas about how to best help people. I will tell you that getting out of training, I was not very excited about my career prospects with not seeing people get better. I was taught to be deathly afraid of using lithium. And when I started to see some of the information, research, evidence on the low doses and started to use them and see some of the results, and I promise you, David, I remain skeptical when somebody comes back and says, oh, that drug was amazing. I feel so much better. And I'm like, we'll see how you feel in 3 months. We'll see how you feel in 6 months. But that has revitalized me because I have seen people actually getting better. And it's not everybody. There are these, there are these factors that I don't understand, but there are patterns, like you mentioned, that I see that help me to better predict. I don't want you to pin all psychiatrists.
Oh, believe me, I have so much. Most of my colleagues are psychiatrists. That's who I work with and so forth. So I'm okay. It's just that this is a show, and we are trying to make some points. You're doing cool with that, but on your last point, we don't understand all that's at work, but we do understand that the encounter between a person who is, the healer, and the person who is looking for an answer, looking for help, who's troubled, who's seeking something, who's hoping something. And we know that the structure of that encounter, what makes it therapeutic and so forth. And so don't minimize, who you are, how you speak, how you look at them, how respectful, how much you smile, all that stuff is very important. And it carries off to you. It may be the drug, it may be the lithium, but we need humility in a lot of things, like, well, maybe it's not exactly what I did, or it's not exactly the drug. We're complex, lots going on in our lives.
We need to embrace uncertainty better.
Uncertainty, and embrace that we might just be, we're like the water carrier. We're not exactly the water. We're helping something along. We're not sure what it is, what the whole process of healing is, because people do declare that they are feeling much better with things that we also think, how could that possibly help them? That could only hurt them. But they want it, they seek it, they take it, and they say, it's good for me. So we just need to understand all of that and not be too stuck in this is what's helping.
Absolutely.
I hope I keep my own mind open to that. I'm open to understanding the biological mechanisms. If I see them, I read English very well. I'm not an expert in chemistry or anything, but I read a lot of that stuff, and it's not there. It's not
right.
there.
There are so many things outside of medicine that we don't understand, yet we still try to treat in some way. I do think that social factors and experiences, I think that they actually change our genetic expression in minute ways. I don't think there's an experience that we can have without having some sort of adjustment to the underlying biology that we have. But again, this is influenced by the environment.
Yes, I agree. Exactly. I agree with you. I'll go there, because we are a body. It's logical that because we experience anything only through our bodies, if not just the five senses or whatever you want to. So this is how we know anything. It's through the body. So I accept that any experience we have changes our body. Not necessarily the other way around, but I accept also that it's at least bidirectional. Things in our bodies change how we experience things, definitely. But to to say it's only, genes to brain to behavior, and here's something for behavior, this drug, I find a little too simplistic.
That idea, I think you and me and some of the best psychiatrists and social workers in the world could get together and find so much common ground, but still see the official report in the medical journal or on TV that says something that most of us don't agree with. It's kind of like the political division that we see in the country. Most of us agree on 90% of the issues within a certain constraints, yet we're still told this public, dogma that, no, this is the truth. You must trust us. So I think that a lot of psychiatrists do understand. I certainly think there's a lot that are ignorant to it. I don't know that it's the prescriber's problem. I think it's certainly. I think it's partially
we haven't really talked about the industry and all the way it frames practice and the way it influences all of us, why it keeps bringing new drugs to the market and expanding its markets to sell its drugs, et cetera. I mean, that's a big, big thing. That's the context of practice. And that's why I think practice is becoming less attractive. Maybe you can't just hang your shingle. I don't know what your type of practice is. All of these things and the way it's standardized, the way you've got to do things, the way there's a standard of care, which is only this.
I have not done so well in some of those more standardized commercial environments. If you can't tell, if I don't agree, I'll speak my piece and do not allow others to try to dictate how and what I'm prescribed. I got fired from one job because the cited patient was somebody who was on 10 psychiatric meds. And I really strongly emphasize that in recovery too, in substance use recovery. And I really emphasize that, hey, this isn't going to happen immediately, but we need to start this process. Let's get you down to 8 drugs. And then it will be a prolonged process. But, I destabilized the patient, which was just ridiculous. Anyway, it's
incredible.
It really is. And we still have incredible. A lot to talk about, but
but
maybe
at least, you're
reconvene and try to jump kind of right into the forced
I'd
psychiatric
love to
treatment?
do this with the forced treatment, and I've looked into it in ideological, ethical, legal, and then the data, like what are the outcomes and who gathers any of this, and why is there not more information on, well, how many people are committed? Do you know? And so I'm the only person in 40 years that's looked at this, just like, oh, how many? How many do we have? State by state. And so there's not much information. We have all these ideas that it's harder, it's this, it's that, but another reality that escapes us. I would love to discuss this, maybe with less passion.
No, let's keep the passion, because I really do. I do appreciate it. Every person that I talk to, I hope to find ways that I can learn and understand more. And I hope to offer that in vice versa as well.
That's terrific.
The forced psychiatric treatment is definitely a huge issue I want to talk about. And then you mentioned the hallucinogens, which wasn't on my outline, but it is something that I think is a really interesting.
It's coming. It's coming to the kids.
And if it were effective for the adults in any ways, the industry is going to have to find a way to get people on it every day. That's going to be the problem, because I really do think it could be very beneficial for a lot of people as kind of a one-off treatment that could lead to them not having the same severity of symptoms for a prolonged period of time, but that is not going to work financially for the industry.
No, that's why they're trying to find a way, with the patent, they're inventing these molecules where they say, okay, we've extirpated out the behavioral stuff or the hallucinogen stuff out of it, which is, and so that's what we're going to study, or they're selling these products so they can be tested clinically. So there's a whole industry of that, of a dozen of the psychedelic drugs they're modified on the basis that maybe this will not induce hallucinations, or because we don't want you to do that. It's not. But in fact, the biggest proponents of using psychedelic drugs are saying, no, the whole point is because you're having these hallucinatory experiences. That's why you'd even want to take it. So what is the deal? So again, it's made into this biological thing that somehow
into
it's reorganizing
into a patentable
and
medication or substance,
not psychoactive. Which is that what it says our psychotropic drugs are. They're not psychoactive. They're just conventional medical remedies for your illnesses. And so anything that is obviously psychoactive, this is the queen of them all. No, we got to sanitize that into anything, just like a conventional chemical. It's really turning the whole paradigm on its head. But yeah, we should discuss what that means, how the use of psychedelics as planned overturns the everyday drug thing. A lot of other things it changes. It's a completely different model. And it's a big threat. How will it be recycled? That's the issue. Everything else is. How will that be recycled again? Took care of that. It's back into psychiatry. And let's continue.
Right.
Like you said,
right.
With the business.
I better stop talking or else we'll never get off of here.
I got to go. Okay. Thank you so much, Ethan.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment. Or, put more simply,
If you need help like this guy, call your own doctor.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.